Hey everyone, welcome back. We're diving into a topic today that's super relevant as you progress through nursing school. We're talking about electroconvulsive therapy or ECT.
ECT.
It's one of those things that can be a little mysterious and maybe even a little intimidating, right?
Definitely.
So, we're going to break it down. We're going to look at what it is, when it's used, and what your role as a future nurse will be in caring for patients undergoing ECT.
Sounds good.
We've got a really solid study summary on ECT that we're going to be pulling from, so we're covering all the bases. We really want to give you that clear, practical knowledge that you can apply in your clinical rotations and beyond, kind of cut through any of the confusion or maybe those outdated ideas that are still floating around out there.
It's important to get the facts straight.
Absolutely. So have you ever, actually thought about ECT beyond what you might have seen in movies or heard, just casually?
Yeah, it's often portrayed in a very sensationalized way, which doesn't help.
Right, exactly. So let's unpack it. Let's get into the real deal with ECT.
I'm ready. Let's start with the basics. What exactly is electroconvulsive therapy?
Okay, so electroconvulsive therapy, or ECT, it's a medical treatment, and it's used for certain psychiatric conditions.
Okay.
And basically what it involves is applying a small, carefully controlled electrical current to the scalp.
To the scalp.
And this actually induces a brief seizure.
A seizure.
I know, it sounds a little intense when you put it like that.
Right.
But here's the thing. This whole process is done under general anesthesia,
Oh, okay.
and they also give muscle relaxants.
That makes sense.
So the goal is to make it as safe and comfortable as possible for the patient.
Makes sense.
And the reason they do this is to really target those severe mental health symptoms when other treatments, like therapy or medications, haven't been effective.
So it's not the first line of treatment.
Exactly. It's usually considered when other options haven't worked or when the situation is really critical and needs quick intervention. Now, it's important to talk about the history of ECT a bit because it helps us understand why there might be some, mixed feelings about it. It was first used back in the 1930s.
Wow, a long time ago.
And it was initially used as a treatment for what was then called schizophrenia. But, the ECT we know today is much different.
How so?
Well, the biggest change has been the use of general anesthesia and muscle relaxants. Back in the early days, it was a different story. They didn't have those tools. Now they use these short-acting anesthetics like methotrexate or propofol. And that makes sure the patient is completely unconscious, doesn't feel a thing.
Right. So no pain.
Exactly. And the muscle relaxants, like succinylcholine, they prevent the strong muscle contractions that could happen during a seizure.
So it's much safer now.
Way safer. So modern ECT, when it's done properly and with all these safety measures, it's actually a very effective and, in some cases, a life-saving treatment.
That's a really important point. It's not the ECT of the past.
Right. It's come a long way.
So let's talk about when it's actually used today. When is ECT indicated?
Okay, so there are specific conditions where ECT is considered, and there's this handy mnemonic to remember them. It's called MAPS.
MAPS. Okay. I like mnemonics. Makes things easier to remember.
Me too. So the M stands for major depressive disorder. But we're not talking about just everyday sadness here.
Right.
We're talking severe, debilitating depression, maybe with suicidal thoughts.
Wow, that's serious.
Or when someone has tried multiple antidepressant medications, like 2 or more, and nothing's working. That's called treatment-resistant depression.
I see.
Also, if the depression includes psychosis, like hallucinations or delusions.
ECT might be an option.
Exactly.
Yeah.
So it's really for those most severe and difficult to treat forms of depression.
Okay, got it. What about A?
A is for acute mania. This is a hallmark of bipolar disorder, where someone has a really elevated mood, racing thoughts, might not sleep much, and they can be impulsive or do risky things.
Yeah, mania can be tough to manage.
For sure. So if someone is in a really severe manic episode and medications aren't cutting it, ECT can be a way to quickly get those symptoms under control.
So it's like a rapid intervention for a crisis situation.
Exactly.
Yeah.
Now, P, that stands for psychotic disorders.
Psychotic disorders, okay.
This includes things like catatonic schizophrenia, where a person might be completely immobile or, on the flip side, super agitated and moving around a lot.
Interesting.
And it also covers those severe psychotic symptoms, like with schizophrenia or schizoaffective disorder, that haven't responded to antipsychotic meds.
So again, when other treatments have failed.
Exactly. And finally, S is for severe other
Other
conditions.
conditions.
This is kind of a catch-all category. It can include catatonia that's not from schizophrenia, like maybe it's caused by really bad depression or another medical issue.
Okay.
And it can even be used for severe depression or movement problems in Parkinson's disease when nothing else is helping.
Interesting.
Also, neuroleptic malignant syndrome, or NMS, it's a rare but life-threatening reaction to some antipsychotic meds. ECT can be used in those cases when other treatments aren't working.
Okay. So MAPS, major depressive disorder, acute mania, psychotic disorders, severe other conditions, that covers a lot of ground, but it sounds like the common thread is that these are all really serious situations.
Yeah, exactly. ECT is definitely reserved for those really severe and treatment-resistant cases.
Okay. Now, I know we talked about when ECT is used, but are there times when it's not a good idea or when you need to be extra careful?
Yeah, absolutely. Those are called contraindications.
Contraindications, okay.
So there's one absolute contraindication, meaning it's a hard no for ECT. Increased intracranial pressure, or ICP.
ICP.
Basically, that's when there's too much pressure inside the skull, and it can be caused by things like brain tumors, a recent stroke, or other stuff that takes up space in the brain.
So ECT could make that worse.
Yeah, because the seizure induced by ECT can further increase that pressure, which is really dangerous, even life-threatening.
Got it. So increased ICP is a no-go. What about situations where you might need to proceed with caution?
Those are called relative contraindications, meaning ECT might still be an option, but you have to weigh the risks and benefits really carefully. Like, for example, if someone has a heart condition, like a recent heart attack, unstable angina, heart failure, or serious arrhythmias, you need to monitor them super closely during ECT.
Right. You wouldn't want to trigger any heart problems.
Exactly. And then there's severe osteoporosis,
Osteoporosis.
because even with the muscle relaxants, there's still a small risk of fractures during the seizure.
Oh, I see.
Certain eye conditions like glaucoma or a recent retinal detachment, those are also relative contraindications because ECT can temporarily increase pressure in the eye.
Interesting.
And finally, high-risk pregnancy is another one. It's not a complete contraindication, but it requires a lot of special considerations and modifications.
So really, it's about individualizing the approach based on the patient's overall health.
Yeah, for sure. It's a case-by-case thing, and those relative contraindications just mean you have to be extra cautious and make sure the benefits truly outweigh the risks. Now, I know this is a question many people have. How does ECT actually work?
Yeah, what's going on in the brain that leads to those changes?
Exactly. What's interesting is that even though ECT has been shown to be effective, the exact way it works, like the specific mechanisms, are still being figured out.
Really?
It's pretty complex, but we have some solid theories based on a lot of research.
Okay, I'm curious to hear them.
So one of the main theories is that ECT helps to kind of reset or rebalance the neurotransmitters in the brain.
Neurotransmitters.
Specifically, it's thought to increase the levels and activity of certain neurotransmitters called monoamines, like serotonin, dopamine, and norepinephrine.
And those are all involved in mood regulation, right?
Yeah. They play a big role in things like mood, motivation, sleep, even appetite. And when those neurotransmitters are out of whack, that can lead to depression, anxiety, and other mental health issues.
So ECT might be helping to correct those imbalances.
Exactly. Another major theory is that ECP affects neuroplasticity,
Neuroplasticity.
which is basically the brain's ability to change and adapt.
To change and adapt.
ECT seems to boost neuroplasticity in a couple of ways. Like, it can stimulate neurogenesis,
Neurogenesis.
which is the growth of new brain cells.
Oh, wow.
And it can also strengthen the connections between brain cells. Those are called synapses.
So it's not just about chemicals, but also the structure of the brain.
Exactly. It's like ECT is helping the brain to kind of rewire itself in a more healthy way.
Fascinating.
And there's even some research suggesting that ECT can impact the HPA axis, which is the hypothalamic pituitary adrenal axis.
The HPA axis.
Is basically our body's stress response system.
Stress response. Got it.
And in conditions like severe depression, the HPA axis can be stuck in overdrive, pumping out too much cortisol, which is a stress hormone.
That makes sense.
And too much cortisol for too long, it's not good for the brain.
No.
So ECT might help to kind of calm down that overactive stress response.
So it sounds like we're still piecing together all the puzzle pieces of how ECT works, but there's a lot of promising research happening.
Absolutely. It's a complex treatment, and there's still so much to learn, but the research we have so far is pretty compelling. Now, let's shift gears a bit and walk through the actual ECT procedure.
Yeah, let's get practical.
Yeah.
What would nurses need to know about each step?
Perfect. So let's start with the pre-procedure prep.
Okay, pre-procedure.
First and foremost, informed consent is absolutely crucial.
Of course, that's standard for any procedure.
Absolutely. The patient has to fully understand what ECT involves, like the benefits, the risks, the alternatives, and they need to give their consent freely.
Right.
If the patient isn't able to consent, maybe because of their mental state, then a legal guardian or a court order might be needed. And as a nurse, you'd be involved in making sure all that is done correctly and ethically.
Got it. So informed consent is a big one. What else is part of the pre-procedure prep?
Okay, so there's the physical assessment. Nurses do a head-to-toe exam, check vital signs, blood pressure, heart rate, temperature, all that,
Okay, standard stuff.
and review any lab results or tests that were done, like an EKG to look at the heart.
Right, you'd want to make sure their heart's okay.
Exactly. And then there's the NPO status. That means nothing to eat or drink for a certain amount of time before the procedure, usually at least 6 to 8 hours.
Why is that?
It's to prevent aspiration. That's when food or liquid gets into the lungs.
Oh, right, that makes sense.
You don't want that to happen, especially during anesthesia. And speaking of meds, medication reconciliation is super important.
Medication reconciliation, yeah.
Nurses need to know exactly what medications the patient is taking.
So you'd go through their med list.
Yep. Some meds can interfere with ECT, like benzodiazepines and anticonvulsants.
The benzodiazepines and anticonvulsants.
They can actually raise the seizure threshold, meaning it's harder to induce a seizure, which makes ECT less effective.
So you might need to hold those meds before the procedure.
Right. And of course, you'd want to make sure the patient has gone to the bathroom and removed any jewelry, dentures, or anything metal they might have on.
Got it. Okay, so we've got the pre-procedure prep covered. What happens next?
All right, so now we're at the actual ECT procedure.
Okay, the main event.
First up is anesthesia. They give a short-acting anesthetic through an IV, like methotrexate or propofol. That makes the patient unconscious and unaware of what's happening.
So they're completely out.
Yep. Then they give a muscle relaxant, usually succinylcholine, and that prevents those strong muscle contractions that could happen during the seizure.
That's key for safety, right?
Definitely. Now, there are two main ways to place the electrodes.
The electrodes.
Yeah, there's bilateral placement and unilateral placement.
Okay, what's the difference?
Bilateral is when they put electrodes on both sides of the forehead.
Both sides.
And this is usually thought to be more effective, but it can also have a higher chance of causing temporary memory problems.
Okay, so more effective, but potentially more side effects.
Right. Now, with unilateral placement, they put both electrodes on one side of the head, usually the right side.
Just one side.
Yep. And this method tends to have fewer memory issues, but it might not be as effective as bilateral for some folks.
So it's a trade-off.
Exactly. The psychiatrist decides which method is best for each patient, based on how severe their symptoms are and their risk factors.
Makes sense. So once the electrodes are in place, what happens then?
So then they deliver a very controlled electrical stimulus.
The electrical stimulus.
It's usually between 70 and 120 volts, and it only lasts for a few seconds.
And this causes the seizure.
Exactly. And they monitor the whole thing really closely, making sure the seizure lasts for the right amount of time, usually somewhere between 20 and 60 seconds.
Okay, that's a pretty specific window.
It is. And the whole time, the patient is getting pure oxygen through a mask to make sure they're getting enough oxygen. They're also monitoring the heart rate, blood pressure, and brain waves.
So it's a very controlled environment.
Absolutely. Now, let's talk about what happens after the procedure.
Okay, post-procedure care. What's the nurse's role there?
So the period right after ECT is super important for the patient's recovery. The nurse is constantly monitoring those vital signs: blood pressure, heart rate, breathing, and oxygen levels. They're also doing frequent neuro checks,
Neurotechs.
making sure the patient is waking up okay, that they know who they are, where they are, and what day it is.
Right, because confusion can be common after ECT, right?
Yeah, and temporary memory loss is also pretty common, especially remembering things that happened before the ECT.
So the nurse would be assessing their memory.
Exactly, and providing comfort measures.
Comfort measures.
Because it's not unusual for patients to have a headache, some muscle soreness, or nausea after the procedure.
Makes sense. You'd want to make them as comfortable as possible.
Right. The nurse might give them meds for pain or nausea.
Okay.
And it's also really important to reorient the patient if they are confused, gently reminding them where they are, what day it is, why they're there.
That must be really helpful for the patient.
It is. And then once the patient is alert, oriented and able to swallow safely, they can start having some fluids and a light meal.
Okay, so it's a pretty involved recovery process.
It is. And of course, the nurse is documenting everything, the whole procedure, the patient's response, any medications given, all of it.
Of course, documentation is key.
Always. So that's basically the ECT procedure from start to finish. But what about the overall course of treatment?
Yeah, how many ECT sessions does a person usually have?
Typically, for the acute phase of treatment, they'll do 6 to 12 ECP sessions, and they usually do those about 2 to 3 times a week.
2 to 3 times a week.
And that can vary, of course, depending on the patient and how well they're responding.
Right, everyone's different.
The goal is to see a good improvement in their symptoms. And then for some folks, they might go into a maintenance phase of ECT.
A maintenance phase.
Yeah, that means they might have treatments less often, maybe once a month, or as needed, just to help prevent their symptoms from coming back.
So it's kind of like a booster shot to keep things stable.
Exactly. Now, we touched on some of the common side effects, but I think it's important to dive a little deeper into those and also talk about the less common but more serious risks.
Yeah, I think it's important to be aware of all the potential issues.
Definitely. So the most common side effects are temporary memory loss and confusion. And that memory loss, it's usually worse for things that happened right before the ECT treatment.
Oh, interesting.
And it usually gets better over time in the weeks and months after treatment is finished. But sometimes some people might have more long-term memory problems.
And what about those other more serious risks you mentioned?
So these are much rarer, thankfully, but prolonged seizures can happen, though the medical team is trained to deal with that if it comes up. They'd use medication to stop the seizure.
Okay.
Heart problems like irregular heartbeats or big blood pressure changes, those are also possible, especially in people who already have heart issues. That's why they monitor the heart so closely during ECT.
Makes sense. What else?
Well, even though they use muscle relaxants, there's still a tiny chance of fractures. And aspiration, which is when something gets into the lungs, that's a risk too.
So it sounds like it's really important for the whole medical team to be on top of things.
Oh, yeah, for sure. And nurses play a huge role in that. Now, it's helpful to think about where ECT fits in with other mental health treatments. Like, how does it compare to therapy or medication?
Yeah, good question. Because there are so many options out there.
Right. So therapies like cognitive behavioral therapy or CBT and dialectical behavior therapy or DBT, those are often the first-line treatments for a lot of mental health conditions.
CBT and DBT.
Yeah, they're often really helpful for things like anxiety, depression, and personality disorders, and they generally don't have any physical side effects, but they can take time to work.
Right. Therapy is a process.
It is. And then there are medications like SSRIs, those are antidepressants like Prozac or Zoloft, or mood stabilizers for bipolar disorder like lithium, and antipsychotics for things like schizophrenia like Risperdal or Seroquel.
Okay, so lots of different medication options.
Yep, and they can be really effective, but they often have side effects that need to be monitored.
Right. So how does ECT fit into all of this?
So ECT is usually reserved for those more severe cases where other treatments haven't worked.
Yeah.
Like for really bad depression with suicidal thoughts, or for mania that's not responding to meds, or for certain types of catatonia or severe psychosis.
Okay, so they're really tough cases.
Yeah. And in those situations, ECT is often more effective and works faster than medications alone.
So it can be a really powerful tool.
It can be. But it's important to remember those side effects, especially the temporary memory loss.
Right. It's always about weighing the risks and benefits.
Exactly. Now, for all you future nurses out there, I want you to walk away from this deep dive knowing a few key things about ECT.
Okay, hit us with the main points.
Number 1, ECT is a legit treatment, and it can be life-saving in some cases. 2, the way it works is still being studied, but it seems to involve changing those brain chemicals, promoting brain plasticity, and maybe even calming down that stress response.
Right, multiple mechanisms at play.
And 3, as nurses, you'll be super involved in every step of the ECT process.
Absolutely.
From getting informed consent to doing those pre-procedure checks, assisting during the treatment, and then providing really good care afterwards.
It's a team effort for sure.
It is. And it's important to know those common side effects like memory problems and confusion, and also be aware of those rarer but more serious risks so you can advocate for your patients and make sure they're getting the best and safest care possible.
Well said. It's all about that holistic, patient-centered approach.
Absolutely. So as you're learning about mental health and getting ready to care for these patients, think about ECT and how it fits into the bigger picture. It's a powerful tool, but it also comes with complexities and ethical considerations.
It's not a one-size-fits-all approach, that's for sure.
Right. And that's what makes nursing in mental health so interesting and rewarding. You're really using all your skills and knowledge to make a difference in people's lives.
Absolutely. Thanks for breaking down ECT today. It was really insightful.
You're welcome. And to all you nursing students out there, keep learning, keep questioning, and keep advocating for your patients. And we'll catch you on the next deep dive.